Good morning to all. I'm going to present the topic paradox. A 26-year-old lady, Miss A. Panchayat worker from West Bengal, a person with the complaints of joint pain since 10 months, fever since 10 months, and weight loss and loss of appetite for past 10 months, and skin lesions for the past 6 months, and throat pain for also for the past 1 month. On history of presenting illness, she was apparently well until 10 months ago when she developed an intermittent high-grade fever without chills, with temperatures recording are showing 102 degrees Fahrenheit. At the same time, she also has developed pain and swelling over the knees and wrists and elbows and metacarpophalangeal joint and proximal interphalangeal joint. Most prominently, the large joints are involved associated with swelling of knees and early morning stiffness lasting for 1 hour. Pain was most severe at knees. Pain was relieved with the taking of analgesics. She also noticed loss of appetite and loss of weight for the past 6 months. She lost 10 kg over the last 10 months. Since past 6 months, she has noted the confluent hyper and hypopigmented rash over the scalp, neck, and back and trunk. There was no associated tightening of the skin or movements of limited mouth opening. There was no history of photosensitivity or oral mucocutaneous ulcers. Since the past 1 month, she had noted the consistent throat pain. There was no history of dysphagia or odynophagia. And also there is no history of cough with expectoration and no history of breathlessness. There is no history of difficulty in getting up from the start and lifting the arms overhead. However, this was not due to the joint pain only. The limited movements was there. There was no history of palmaresis, palpitations, chest pain, pedal edema, orthopnea, paroxysmal nocturnal dyspnea. There is no history of bloody or frothy urine or decreased urine output. There is no history of Raynaud's phenomenon or hard painful lumps below the skin surface. There is no history of venous or arterial thromboly. There is no history of outside travel. There is no history of exposure to the domestic animals or pets. There was no history of immunocompromise. During his admission, vital signs are showed. Pulse rate was 120, regular in rhythm. All peripheral pulses were felt. BP was 170. Respiratory rate was 18 cycles per minute. Saturation was 98% room air. Temperature was showing 102 degree Fahrenheit. As he was presented with pallor, no icterus, cyanosis, or glubbing, or pedal edema, journalist lymphadenopathy. Thyroid examination were normal. Breast examination normal. Oral cavity normal. And she was presented with the salt and pepper pigmentation over the upper back and chest and forehead. And the tender joint counts were 28 and the swollen joint counts were 4. Bilateral coloboma iridae were also present. CVS no significant findings, and RS also trachea and central present, bilateral normalized present, no added sounds. For abdomen, soft, no tenderness, trough space dullness was present, and no shifting dullness. And central nervous system examination, no significant any focal neurological deficit. The syndrome complex of classical paradoxia of unknown origin with rash, joint pain, and constitutional symptoms with sore throat. And she was also presented with this salt and pepper rash with no Raynaud's phenomenon and no hardening or tightening of the skin. With the syndrome complex, our differential diagnoses are infections, tuberculosis, brucellosis, syphilis, infective endocarditis, melioidosis, and malignancy of Hodgkin's or Langerhans lymphoma, solid organ malignancy with paraneoplastic arthritis. The inflammatory disease, Takayama arthritis, extracranial giant cell arthritis, rheumatoid arthritis, and systemic lupus erythematosus, Still's disease, and sarcoidosis. Initial investigation workup showed CBCS hemoglobin was 7.9, MC was 68.6, MCS 21.8, microcytic hypochromic anemia, total leukocyte counts for leukocytosis neutrophilic predominant, platelets are normal, urinated source, no significant proteinuria. LFT function also showed there is no elevated transaminase or bilirubin level. Renal function test also showed creatinine were normal. BBVS also negative. Serial blood culture also sent. It showed no growth. The ANA also negative. ESR and CRP was raised. RA factor also was less than 8. Anti-CCP also was normal. SCL 70 also negative. Anti-RNP negative. Anti-centromere antibody also was negative. JC was also in the normal limits. Heavy metal screen also was done. It showed negative values. LDH values were rise, ferritin also was rise. And the bone marrow was also done. It showed partly hemorrhagic cellular marrow with trinary hematopoiesis. And the imaging shows CT neck, thorax, and abdomen pelvis. Multiple borderline nodes were present in the bilateral axillary region. Mild splenomegaly only was there. And for the rash present over the back and chest region, for that dermatology opinion obtained and dermoscopy also showed probable vitiligo, but the site of involvement is not classical. An eightfold capillary scope also was done. It showed normal. And UC musculoskeletal system also showed mild synovitis in the both wrist joint and no efficient tenosynovitis involving the extensor and flexor tendons, and efficient in the metacarpophalangeal joints and the proximal interphalangeal joints. No evidence of the synovitis or articular surface of erosion. More likely, the features are suggestive of inflammatory etiology. But she didn't fit any other inflammatory disorders with our differential, only she fits in the adult onset Still's disease. It's a rare systemic inflammatory disorder of unknown etiology. It begins at 16 years of age, mostly involves mostly affecting the females, and also after 36 years of age also it will affect. It won't occur in the elderly women. Inflammatory side, the mechanism of the adult onset Still disease is not fully known. Some of the studies are solely inflammatory cytokines, 1 beta and TNF alpha, interleukin 6, interleukin 8, and interleukin 18 also was involved. And there is a two adult onset Still disease present with two clinical presentation, articular form with the arthritis, the disease onset, and systemic form. And the clinical features of the adult onset Still disease, the quasi fever, frequently greater than the more than 1 or 2 degrees Fahrenheit, and evanescent and salmon colored macular rash over the trunk and extremities. It often coincides with the fever spikes. It also sparing the face, palms, and soles. The pharyngitis was non-suppurative aseptic pharyngitis, and polyarthralgia most commonly involve the large joints, lesser degree involvement of the small joints. And the lymphadenopathy was 50% of the patients with adult onset Still's disease was present with lymphadenopathy, most prominently cervical. And in the lymph node biopsy also, most of them are showed only the reactive hyperplasia. And splenomegaly was also present and the serositis. The laboratory abnormalities are in laboratory markers show like leukocytosis, elevated erythrocyte sedimentation rate, and CRP, increased levels of serum ferritin. The adult onset Still's disease with another one, glycosylated ferritin fraction also was in the important biomarker with the elevated serum ferritin levels. The fivefold increase in the serum ferritin level with the low glycosylated ferritin that was less than 20% was 90% toxicity in the adult onset Still's disease. Adult onset Still's disease subtypes are monocyclic form, self-limited course lasting for few months, and polycyclic form, multiple recurrent flares of systemic or articular symptoms alternate with the disease-free intervals. The chronic form, persistently active disease, polyarthritis also was major complaints of the patients, and they requires ongoing therapy. The diagnostic criteria for that adult onset Still's disease, Yamaguchi's criteria was 1992. The major criteria involves fever at least more 39 degrees Celsius, intermittent lasting 1 week or longer, arthralgia of arthritis lasting 2 weeks or longer, or typical rash, leukocytosis more than 10,000 with neutrophilic predominant more than 80%. And minor criteria was sore throat, decent development of significant lymphadenopathy, hepatomegaly or splenomegaly, abnormal liver function, and the negative test for ANA and rheumatoid factor. The Yamaguchi criteria diagnosis requires 5 or more criteria, and majorly involves two of them must will be the major criteria. Our patients were presented with the met the criteria of fever, arthritis was there, rash, and leukocytosis. 15,000 leukocytes are present, and sore throat and splenomegaly, and ANA and rheumatoid factor also was negative. Another criteria for the adult onset Still's disease, Fortrell's criteria. The major criteria was spiking of fever more than or equal 39 degrees Celsius, and arthralgia, transient erythematous rash, sore throat, and neutrophilic predominant more than 80%, and glycosidated ferritin was less than 20%, and maculopapular rash leukocytosis more than 10,000. The Bartels diagnostic criteria requires at least four or more major criteria and plus three major plus two minor criteria. Our patients met with this criteria involving the fever, arthritis, rash, polymorphonuclear cells more than 80%, and sore throat. The leukocytosis were more than leukocytosis were 15,000. The management of the adult onset cell disease are mild to moderate and severe. The mild to moderate is non-disabling fever, rash, arthralgia, and mild arthritis, and absence of macrophage activation syndrome. The moderate to severe category was additional presence of the clinical significant serositis, moderate to severe and debilitating arthritis, persistent high fever with ongoing treatment of the NSAIDs, and also involvement of the internal organs. The management, the guidelines, German Society of Rheumatology has presented the paper regarding the guidelines of the management. I will tell details about the mild, moderate, severe category. That depends on the upcoming slides.
You can just tell us what we did with our patient. Due to lack of time, you can just conclude by saying how we managed our patient.
Our patients was initially acutely was present with the polyarthralgia, initially managed with NSAIDs, and along with that, rheumatology opinion also obtained with that 0.5 mg of 5 mg kg of steroids with the methotrexate 15 mg was initiated further. But our patient did not fit with the criteria of severe category, so we didn't start with the biological agents or biological agents. We didn't start with them.
Thank you for that presentation. Any comments from the audience? Can you describe the typical rash that the Yamaguchi's criteria says?
Ma'am?
What is the typical rash
salmon
that was part of the criteria? Yeah.
The salmon colored rash
more
commonly involving the upper extremities and the chest region, but it usually more prominently in the along with the fever spikes and the disappearance of the rash also after the fever settles. The more prominently the fever will occur in the late afternoon and early evening times.
Did the patient have a typical rash?
I didn't get the images of the patient.
But you've seen the patient from those images. Do you think it's a typical rash?
Typical rash.
It's a typical rash. Okay, because you mentioned salt and pepper pigmentation.
The initial with the dermatology also we had obtained, ma'am. There is not fitting into the salmon. We could not conclude that it is initially was adult onset cell disease. After evaluating only we know about the